Let's not get too much behind schedule. We have two major sessions this afternoon. The first one will be on surgical aspects, and you'll see that some approaches have been evolving lately, and it is a good news. So we will have three presentations on this topic, and the first one, and we decided to give the floor to a profession that we do not always hear during these conferences, anesthetists, because they are very involved in such surgeries for patients with locomotor issues. And so it was very important to have with us one of the most important, of the preeminent anesthesists in France. He is really trying to find the most adequate solution of anesthesia for the patients. And he is also the person in charge of everything happening in the peri-operative period, so the 48 hours before, and he is making the decisions on the care that are given to the patient. So thank you very much. And so we will be talking about peri-operative period, preparing the polio patients for surgery, including dealing with anesthesia. You have the floor. Good morning, everybody. First of all, I would like to express gratitude to the Professor Alain Yenlik and also Robert Cordier for inviting me to take the floor today. I work for the Raymond Poincaré Hospital in Garches. I've been there for a few years now. As you all know, this hospital is targeting handicapped, disabled persons. Let me come back to the previous slide.
Donc, hôpital tourné.
So our hospital is targeted at disabled patients and with different kind of diseases, including, of course, polio. As an anecdote, we had in iron lung during the epidemic of polio, and in our emergency room, we created this during the epidemic in the polio epidemic in the 60s, and there you have the iron lung, and on the side you have the medical team of the time. So polio is a very well-known term in all the countries, all the classes. However, the disease in itself is very unknown, except by the patients themselves. They often know it better than anyone, to be honest. But the healthcare workers and also the doctors that are working directly with polio patients do know this disease, but when you go to other doctors, other healthcare workers, they don't really know the disease, and anesthesists are no exception to that. And so we've realized that when we work with polio patients, we learn more than through literature, because there's not much there to find. So my presentation today will be axed on two parts, really. The first one would be a bit more about definitions that you, of course, know. And I think the other speakers have already mentioned these definitions, but they are very important to understand better what's happening and to better adapt the care of these patients in anesthesia and also peri-operative medicine. As you all know, this is a highly contagious viral infectious disease caused by one of three strains of viruses. The WHO launched a campaign to eradicate the disease through mass vaccination, but we are not there. So there's a high number of post-polio or polio cases, polio survivor, we call them too. So the terms are varied, but at the end of the day, they are the same people. And so they will be undergoing surgery or anesthesia for different procedures. So when we talk about surgical procedures, of course, the main issue is safety. And to develop safety, we need data, we need literature. Sadly, if you do a research on anesthesia and polio on PubMed, so the search engine we all use, we only have 24 results for anesthesia and polio. So we've found only 2 retrospective studies and a general overview that was published in 2005 by Lambert in the Anesthesiology Review journal. So it is very important and it has concrete implications. So you can see the point A, a scheme of a motor neuron. You can see that the nucleus, so this is the spinal cord. So the nucleus then has an axon, and then the nervous termination that goes into the muscle. And in the polio, these motor neurons are destroyed, which leads to muscular paralysis. And so you can see regeneration after a few months through appearance of new nervous terminations on the muscles, so the polio patient recovers full activity of the muscle. But then, after years or decades even, the post-polio syndrome appears with degeneration of the the motor neuron, which leads to atrophy of the muscle and then paralysis. The hypothesis is that the motor unit is overused, which does damage the termination, the nervous terminations, and leads to degeneration.
Donc ceci implique
This means that this creates some symptoms. So we can see a late degradation linked with different factors, with aging, with weight gains, but also other comorbidities. And it leads to fatigue, to weakness, and difficulty of walking, of climbing the stairs, and so on. But also falling, of course. As we could see in the different studies by Professor Yolani, we estimate 50,000 polio patients in the world in 2013. There are other appearances of these diseases, but we will talk about tendons and tendinitis.
Due à une surutilisation du membre.
Because the limb is overused, solicited, so you see the patients. We see often patients in Garches, and my colleague will talk about this too. And we offer them hip replacement or knee replacement on the healthy limb to these patients. And there are also surgery complications such as respiratory deficiency due to the muscular weakness, but also possible deformation of the spinal cord.
Récente et surtout importante.
In 2016, a study was pretty interesting, linked with anesthesiology. So it was a retrospective cohort study that compared two groups, a control group, 200 patients, and a polio group with 100 patients. And they were undergoing several types of surgical procedures, and we can see that the objective was to compare the effects of the anesthesia and the methods used, and also see what were the after effects of the surgery and the complications that we could see. So on table 1, you can see the demography of the first group. So you can see that they are quite comparable on all aspects. I've tried to show you all the categories, and the only difference was in the neurologic deficiencies. Of course, it was to be expected, with 36% in the polio group that had these kind of deficiencies at the neurological level. For the other group, general anesthesia was used in 86% of the procedures, no peculiarities, no differences between the two groups. And let me come back to the results of this study at the end of my presentation. Now, let's talk about the perioperative period. So perioperative means assessing the patient, talking to the anesthesist, investigating on the different aspects, and then going to the surgery in itself and starting the anesthesia, and finally the post-operative period, which starts in just after the surgery and can last for 48 to 72 hours. For the pre-surgery assessment, well, it's a clinical assessment that tries to assess the risks based on the history of the patient, with different categories we use, but also according to the nature of the surgery, if it's elective or not, prolonged or not. But also we look at the condition of the patient beforehand and the potential risks and after effects of the surgery. If everything is clear, well, there's no need for complementary explorations and, for example, blood tests. So we have the ASA classifications, so the American Society of Anesthesiologists. So ASA1 is no pathology, and ASA4 is a very high risk. Now, the assessment that is specific to polio patients, we will gather several elements, such as the history that has come before polio. We could have diabetes, for example, the age of the patient when he contracted polio. It is important and might give you information on the scale of the disease, the different symptoms, a little linked to the disease, with the possibility of apnea and dyspnea, the importance of the partial recovery, quantification of the disease in order to anticipate the possibility to have a post-polio syndrome. We also have to assess the pain, if they take pain killers on the long term, because they could take opioids for chronic diseases, and it has to be taken into account when you are preparing the patients and maintain them in perioperative period. And you don't want, of course, to compound the situation by overdosage. you also have the question of the vertebrae and know if there are no difficulties, because it could lead also to respiratory issues. If need be, we could call upon a rehabilitation practitioner to ask if there's a necessary treatment to be applied. Now, the most important thing is the respiratory examination, really for the peri-operative period, because the lung can be affected, more or less. Sometimes you have no symptom at all. That's the first case, but you can also have the need for a positive pressure ventilation at night, or even a positive pressure ventilation all the time. So all the symptoms requires to do RX for the lungs, or also assess the level of gases in blood. It's very interesting because when there's an issue with the respiratory capacity of the patient, we see a decrease in the respiratory volume, and I will explain what I mean by that. We are trying to assess if there's a sleep apnea or other kinds of respiratory issues, and to see if there's a need for a sleep apnea device. But of course, you can always ask a specialist doctor to take this into account. So, this is the result of a respiratory examination. So, we have the volume of air that is breathed in every time you breathe. You also have the VRI. It is the maximum volume that is moved by a normal breath. The reserve volume is the one that is being expired after a normal expiration. And when there's a respiratory issue, you see that there is a restrictive respiratory limitation, so the volumes are decreased. These two volumes are decreased. So the vital volumes, really the maximum volume that can be moved, and also the total lung capacity. So it is the total volume that can be of air that can be contained in the lungs. Well, these two figures are decreased in case of respiratory issues, and this can lead to risks for the surgery.
Associé à l'évaluation respiratoire.
Now, we also focus on the
éléments pour nous fondamentaux de
intubation conditions. So we do a normal assessment. We try to see if there have been any histories of intubations. And we use the malampathy categorization. We try to see if we can see clearly the mouth and the uvula, and we will also try to measure the distance between the teeth and
déformation rachidienne
and the chin. So when there's a difficult intubation access and also a respiratory issue, this can lead to very high risk because intubation will be difficult, so you will need specialized devices, equipment, and you have to be ready to use what we call the algorithm. In case of difficulties, we have to switch to step B or C.
L'évaluation préopératoire s'attachera.
Now, this assessment will also try to look for cardiovascular history, any high blood pressure, and also heartburn that could explain that there is a situation that could be a risk. For example, you could inhale what you have in your stomach during the procedure.
Péropératoire.
Now, the phases that happens during the procedure. The first question we have to tackle is which technique, what are we using, which method for the anesthesia, when it's possible, of course. If we have an abdominal surgery, of course, you have no choice, you need general anesthesia. So we have to choose between a local anesthesia and a general anesthesia. As I was explaining, there are clearly no data in literature, and we just have case reports. And in the rachial anesthesia is a controversy because it could compound a neurological issue that is already there. So it's only in theory. We do not really know what happens. Also, when we have the some syndromes that can happen, for example, with different micro traumas because of the anesthesia and the toxicity of the products, this can lead to some kind of syndrome. You can have also a damage to the spinal cord that can, of course, lead to paralysis and sphincter issues, but these are after effects that are very rare.
Plus susceptible à ces complications, c'est que
how can we know if these people are more susceptible to this kind of after effects? Well, motor neurons there are less motor neurons, simply fewer motor neurons, so you will be more sensitive to the usual dosage. However, therefore, we should decrease the volume, the dosage of drugs we use during anesthesia. There you can see a plate with fewer motor neurons. So in theory, there should be more sensitivity to the drugs.
So the local regional anesthesia is the procedure of choice for polio patients. Another study from Brazil published recently included 133 patients with PPS. 66% of them had lower limb neurological sequelae. So the rush anesthesia was the technique chosen in 64% of cases. And finally, the complications were common for other than polio patients and all patients having rush anesthesia. And there was no worsening of their neurological worsening after a monitoring of 24 months. So in the end, the technique choice will be based on a case-by-case basis, balancing benefit risk, the type of surgery, whether it's urgent or scheduled, the risk of bleeding, and the seriousness of PPS and other diseases. So for installing the patient in the ER room, we have to make sure that the patient is, that this position will not worsen the patient. The patient is more sensitive to cold, so we have to warm up some liquids. For the courier, we have to check this with a very strong monitoring of the patient, and it is essential for some patients, and we have to decrease the dose, not to have what we call residual curization. So that can be due to the use of some anesthesia gases, the halogen gases. So at the end of the surgery, we remove or reduce the treatment. We have to tackle the pain because that has to be a multimodal treatment because of the opioid doses that are already used. And the more painful is the patient in pre-surgery, the more difficult will it be to manage the pain. Now, the post-surgery period is a key issue. We have to check especially the respiratory issues, and we have to do a longer monitoring time. We have to set up the patient and use treatments if necessary. So to come back to the results of the study, there was no particular complications, respiratory complications for polio patients. And we can recommend the RAC protocol, fast recovery procedure, to reduce the length of the stay at the hospital to guarantee the quality of care by making sure, especially by monitoring particularly well the post-polio patients. And we encourage ambulatory management of the patients. It's a benefit for the polio patients as for all patients in general. So at the end of the day, the key message is what you should retain is that we favor local and regional anesthesia if possible by reducing the dose of prescription drugs. We have to do continuous monitoring of these patients. We need closer monitoring in the wake-up room, and we have to take into account the chronic pain and the consumption of opioids of those patients. And at the end, we need to encourage ambulatory surgery and the fast recovery procedures. So at the end of the day, the polio patient is a patient like any other. Thank you very much, Chawki, for this comprehensive presentation. Is there a quick question for Chawki, because anesthesia is a bit special? I have a question about the method to limit risk. Is there, I can't find the word, to sedate people? Is there a particular technique? Hypnosis, yes, it does exist in one reference center, but the success of hypnosis is not guaranteed, and it cannot be an absolute alternative to this day. Thank you. Is there another question in the room? Yes. Oh, you want to go back to the first slide? The last one. Concerning the recommendations you made, you said that the polio patient was a patient like any other. So I was thinking of addictions. In the questionnaire, if I remember well, in the questionnaire that we have to fill in before anesthesia, we are asked if we consume alcohol, cigarette, cannabis, and others. So for the pain and for certain things, as polio patients, we have cannabis. We're allowed to consume cannabis. I would like to know what are the risks of that. Well, addictions are searched for any patient. Yes, that's the part of the traditional questionnaire that we ask any patient to fill in: alcohol, tobacco, drugs, and general drug, because cannabis, has some therapy indications. So the idea is to do a stock count when we do the pre-anesthesia consultation to know what's been taken, and then to see whether he can continue consuming that, because if he smokes cannabis, maybe it will not be compatible for the first 24-48 hours. So maybe we can replace that by biformoral. So that will be taken into account, and maybe it can be replaced by other substances.